as we have been doing, I'm going to go through an assessment, a general assessment process. Then I'm going to essentially stage what would be a treatment process, take you through the positions and the rationale for why I'm doing this, to essentially unite a lot of the concepts that I've spoken about over time: patient positioning, contractors control, how you go about performing treatment, activating forces, things of the like, to start to sew those together so that there's some idea. Now, as far as assessment's concerned, I just reiterate: macro identifies micro, large movements identify smaller subcomponent problems. Be organized in your approach, so have an approach for diagnostics to find things and generally get everything to move in a large way, and also preferably patient active before patient passive. Sorry for messing those up. So as I've said before, as far as the diagnostics is concerned, I have my own process whereby I generally go in the coronal plane only when checking the vertebrae, but it's not exclusive, right? So we'll have you bend your left, bend your right, okay? And in this case, the patient bends better to his right in the T-spine than to the left. So we're going to call, generally speaking, some form of motion asymmetry in the T-spine. So I've essentially got the information that I need out of the vertebral column. I'll have you lay on your back. So I still go ahead and check everything. I'm not negligent. All right. Check through the lower limb to see if anything large shows up. Right, and again, because this is essentially simulating, we're going to pretend as if I'm not finding anything and everything's looking more or less fine and even, but I'm going through the process so that as these videos go along in totality, what you end up seeing is consistency in my diagnostic approach, because I'm telling you that I want to have consistency in my diagnostic approach, right? So I go through the same thing consistently so that it is easier for me to find things. All right, so we're going to pretend like everything looks okay with all of those. I check through the neck. And again, we're simulating. So we're simulating that the head turns fine to the left, or sorry, fine to the right and not so fine to the left. Now, what I'm going to do is I'm going to immediately choose to treat the neck first. And the reason that I do this is because not all tables have face holes in them, or a place for the patient to keep their face in a neutral position. So we go ahead, and so he moves well to the right and not to the left, so we can go indirect. So we go to soft tissue ease, the soft tissue gets soft. I can add activating forces, so compression, mild torsion. You really don't want to do much of that in the neck, but I can do compression and distraction, just checking what would make it go softer. Then I can go direct, so into bind. I can do patient active approaches here, so push the shoulder down, right? Let it relax, push the left shoulder down, let it relax. So that's the patient active approach. And then we would recheck the neck and see if it changed, right? So again, for simulation purposes, because I'm pretending the neck goes farther to the left and goes fine to the right. Now I want to address the problem that I found in the T-spine, so while you flip to your front. As he bent well to the right and not so well to the left, I'm going to believe, or begin to believe, that the soft tissues on the right will shorten and do not like to lengthen. So those are the tissues I'm going to consider short. So I come to the left side of the patient so that I can work on those tissues. Prior to that, I'm going to do another general check of the spine. So take a deep breath and let it out. Right? So minimal motion in the T-spine, so I know that I have more confirmation that what I found when seated was reasonably correct. So I go soft tissue to the right side of the T-spine. I want to work perpendicular to fiber direction, as we often do, right? So I would hold, and I would go through those soft tissues. Right? Now, because the ribs on the right will collapse and the ribs on the left will not collapse, my next step is to work on the left ribs to get them to collapse a little bit better. So I would essentially, well, I'll show you in a moment, but I'm going to push the ribs into the vertebral column to try to create some motion in them. And if I hold onto the ribs while the patient's just laying on their side and they breathe, then essentially I'm holding the ribs still and letting the vertebral column move. So I work through here. I would retest to see if I got my change. Take a deep breath. And again, we're simulating, so it doesn't really matter if I got the change. So what we're going to have you do is lay with your left side up. There we go. So my back is more or less going to be to the camera, But basically what I'm talking about is I just squish into the ribs. So I stay tight to the patient, I lean into the ribs, and as he's breathing, the ribs are being held relatively still, and the vertebral column is moving. So essentially what I'm doing is I'm having the vertebrae move in relation to the relatively still ribs to get some of the motion that I'm looking for, right? So that would be where I would go. If I feel it necessary, I can go into some rib raising using the arm as a long lever, right? I may not necessarily feel this necessary, but I could do that, right? And we'll have you on your back. And one of the things that I have a strong tendency to do when I found something in the T-spine is to, after the patient has been prone and I've worked through the soft tissues and I've worked through the ribs, right? So the reason that I kind of go around is because I want the soft tissue, so I want the back exposed for the soft tissue. So patient positioning, the anatomy should be exposed, free to move in the plane or planes required, and preferably visible. So if I want that soft tissue, I want the patient in prone. I go to the side that the ribs don't collapse well on. So if he bends well to the right, the ribs don't collapse as well on the left. So I want to go to those ribs to see if I can interface with them. And then the thing that I would often do is essentially go to the sternum, because I can interface with more or less all of the ribs from the sternum. So I go to the sternum and then I would hold on to the sternum. So as the patient breathes normally, I can compress and I can follow, right? So I'm holding the sternum relatively still, which means in some sense, not perfectly, but in some sense I'm holding the ribs somewhat still. And then the vertebrae is moving in relation to those somewhat still ribs. Now, as the patient breathes in and pressure comes on, I can essentially hop off, right? So I'll do one of those really quickly. I've done this in videos previously, so you can go and look for those. But just as the patient breathes, as the pressure goes up, I hop off or I jump off quickly. That changes the size of the thoracic cage relatively fast, so you get a fast change in pressure, changes the speed at which it expands, changes the speed of the respiration. But that's essentially what I would do. So then I've gone through the neck first, I've gone around the T-spine or around the thorax, just because of the relationship of the ribs and the vertebral column. So then what I want to do is go back to the test. So I've already retested the neck and the neck was okay. So I have you sit on up and we go back to the initial test for the vertebral column, which is where I would look for the change. So again, you want to remove redundancy. If you found problems in two tests, so the neck and the vertebral column, so moving in the coronal plane, then you go back to that. So we have you bend to the right because it was the good way, and bend to the left, so I have my comparative, right? And again, we're simulating. In this simulation, we'll pretend like bending to the left got better. Now, the reason that I went to the right first instead of going to the left first, because my consistent way is to go to the left first, I wanted to go to the good motion first and compare it against the less free motion. So I switched sides because I wanted to have the good side first in order to compare it to the bad side or the less functional side. It works a little bit better in my brain. That may not work well for you. You may need to consistently just go left, right, left, right. Whichever way works for you is fine, but I went right first on the retest, followed by left, so that I could see the good motion first, followed by the less functional motion, to see if they were similar. It's essentially cognitively refreshing for me. Now, all that said, another example of combining assessment and treatment in a simulated fashion.